Division at Johns Hopkins School of Medicine. You guys can give a round of applause as she's welcoming up. Here we go. Clinical Director, IBD Center, gastroenterologist, simply Johns Hopkins.
Good morning. Good morning, everyone. I look surprised because I didn't expect to be, called on stage right away. So, good morning, everyone. I hope you are relaxed after the yoga sessions, after a fantastic breakfast. For a gastroenterologist, it's always unnerving to figure out if your audience is ready to talk about poop early morning. But walking through the hallway and seeing the toilet swings and the toilet paper, I'm like, I'm in my place here. I belong here. This is my people. So I want to congratulate Melody and the whole team of Kochi for this amazing event, and it's an absolute honor to be here. So today we're going to talk about IBD. Why? It's complicated. That's why as gastroenterologists we have annual meetings and continuous research and trying to understand what's going on. But I think it's important for everybody, every patient living with IBD, everybody taking care of IBD, every advocate for patients with IBD, industry, clinician, nurses, everyone, to really understand what's going on in the body of a person living with IBD, to understand the symptom, to understand the experience. So this is what I'm going to try to do. I don't pretend to understand exactly what's happening if you're living with IBD, but that's what I strive for in my clinic. And my goal today is to help you see why you're having these symptoms. Why do I have GI symptoms? Why do I have the pain, the diarrhea? Why is that a pain in my butt? Why don't I feel good at all most of the time? Why do I even have IBD? All right, so we'll go over this together. So, as you know, inflammatory bowel disease, we have two diseases, main disease, Crohn's disease and ulcerative colitis. These are chronic inflammation of the gut, and I'll show you a picture of what that means. And when you have IBD, you have episode of flares where the inflammation is up and you have more symptoms, and times where the inflammation is more quiet and you might not have symptoms. More than 1.6 million people live with IBD, but actually some data suggests more than 3 million people live with IBD in the US. And on average, men and female are equally affected, and it can really occur at any point in someone's life. So very early onset IBD have been diagnosed even in people, in infant of few months old, and then we have people in their 70s being diagnosed with IBD. But the peak time where IBD starts is in young people, between age 15 and 30, and there's another peak later in life. Traditionally, this is a disease that we see more in Caucasians, more than in minority group, but now what we're seeing is an increase in the incidence of IBD everywhere for everybody, all around the world, in countries where traditionally we didn't see IBD, and in the US, minorities, African American, Hispanics, this is where we're seeing the highest increase in the number of new cases in IBD in recent years. Immigrants coming from countries where there's no IBD or the incidence of IBD is very low, once they get to the US, their risk of developing IBD is the same as people who were born and raised in the US over multiple generations. So it's important for us as clinicians and as a community to recognize that IBD can affect everyone, and that's why we're here. So let's talk about terminology and what do we mean by ulcerative colitis and Crohn's disease, and what is the difference? I often get asked by patients, do I have colitis, do I have Crohn's, what is it? So just kind of a 101 on the GI tract, you have your food pipe, your esophagus, your stomach, your small bowel, 25 feet long, that's mainly responsible for absorbing all the nutrients. And then the small bowel connect to the colon, and the colon only job is to make stool. So by the time, everything you ate, that nice breakfast you had this morning, all the good nutrients are absorbed. By the time things goes from small bowel to the colon, it's already stool. And all the colon is doing is sucking the water out of the stool to make the stool formed. And so now you can see that if the colon is inflamed and not able to do that function while we're having diarrhea. Okay, so the colon we divide it in different segments, so it's for us to orient ourselves. The last segment at the bottom is called the rectum. So you'll see that for ulcerative colitis, the inflammation in red can always start in the rectum, okay? So the rectum is always involved, and it can involve more part of the colon in a continuous way, and then stops at some point. And we don't know why some people have colitis only in the rectum, colitis in the left, the entire colon, we don't know yet, okay? When the ulcerative colitis only affect the rectum, that's what we call proctitis. So, you know, and I think as physicians, we make sometimes the mistake to use these terms with patient thinking they understand what we're saying, and patient will stop me and say, do I have proctitis or ulcerative colitis? So when you hear proctitis, is ulcerative colitis limited to the rectum? And then if it's the whole left colon, this is what we call left colitis. If it's involving more than that, we call that pancolitis. So ulcerative colitis only affect the colon, always the rectum, and extend in a continuous way. Crohn's is a different beast. It can affect the GI tract really from the food pipe to the rectum. But the most common location is the last part of the small bowel that connects to the colon, what we call the ileum. And so people with inflammation of the ileum will have Crohn's ileitis. And so ileum is often involved, the colon is often involved, and often we have a combination of ileum and colon involved. So your doctor might say you have Crohn's colitis when it's the colon that's inflamed, okay? So Crohn's is different in the fact that it's more of a patchy inflammation, right? So you have areas that are inflamed, areas that look normal when we're doing the endoscopy. So how do things look on the inside? This is what, as gastroenterologists, we spend a lot of time doing our colonoscopy. This is a normal colon, okay, a happy colon after a good prep. It's pink, like a baby. It has these like nice vascular pattern. You know, that's what you see, kind of like a web of red. These are the vessels, okay? This is the colon of somebody with ulcerative colitis. So it's important also to understand that for every patient with UC, it's a different disease in terms of location, in terms of severity, in terms of symptoms, right? So I have on your left side a milder form than on the right side. So if the way I describe it is like somebody took sandpaper and rubbed it on the colon, right? You don't see that smooth lining anymore. It's not pink. You don't see the vessels anymore. It looks very granular and red and angry and angrier in a more severe disease. With Crohn's, it's different, and it can be, again, different severity. You can see these like on the far left, you know, like these little round ulcer, like somebody took a toothpick and poked the colon. You can see in the middle, somebody scratched the colon, right? So you see that ulcer, that white area that is like somebody scratched the colon. And then when it's very severe, it looks more inflamed, more angry, right? And so with Crohn's, if you look at the middle picture, actually, you'll see that you have that ulcer at 6 o'clock, and around it, the lining looks fairly normal. So that is how on colonoscopy we can tell, is this UC or this is Crohn's? Because with Crohn's, we'll see deeper ulcer, more angry ulcers, and in between, we have a normal mucosa. All right. Crohn's can also cause complication because Crohn's, the inflammation that we see on colonoscopy is the inflammation we're seeing on the inner lining of the colon, but that inflammation actually involves the whole thickness of the bowel, whether it's colon or small bowel. And when it's involved the whole thickness, the structure of the bowel changes, and you can have complications such as stricture. So you see how here the opening is narrowed down, and this is where people present with blockage from Crohn's disease. All right, so I hope by looking at these images and by going over this, we now understand why we have these symptoms, right? If your bowel is inflamed, if your small bowel or large bowel are inflamed, they're not able to suck the water in, you have diarrhea, they're even actually leaking water out. Just think about if you have a bad wound, right? It's just, you get like this leakiness that happens, you get diarrhea, you get pain. Just looking at these pictures, you feel like you want to crunch, like this is painful. You have blood and mucus from all this ulceration, inflammation. And some of the symptoms that are very, very burdensome for patients are like urgency and tenesmus. And what that means is urgency is that you have to run to the bathroom. You can't hold the stool when it's coming, right? And that could be for many reasons. If you have loose bowel movement, it's harder to hold loose bowel movement than if it's formed. But also if you remember that rectum, that last part of the bowel, the rectum, the bottom. The rectum is supposed to be like a reservoir, right? It's like, this is where the stools sit. And, you know, if you're sitting here and you need to go, but you're like, I don't want to miss anything from Dr. Shahbadi, amazing talk, you can hold it, right? So it's a reservoir. You can sit there, you can control it, and then it's only when you build enough stool and pressure and volume that you need to go. All right. But when this rectum is inflamed, it's irritated. It can't hold anything. As soon as you have a little bit of stool, a little bit of air, a little bit of gas getting there, you need to go. Or if that stool that's there is liquid, it's very hard to hold liquid as opposed to something solid. So urgency often happens if you have watery diarrhea, but also if your rectum is inflamed. But also sometimes, unfortunately, even when we heal the disease, when the rectum is healed, we still have urgency. And that's very frustrating, right, for people living with IBD. That I'm taking my medication, I'm doing all the right thing, my doctor telling me my colon looks great, I'm still having the urgency. It's because when this rectum has been inflamed over and over again and your body is trying to heal it over and over again, it scars down and becomes very stiff and tubular. So instead of having that like cup or vase shape, it's now like straight. And think about, if you want something to hold, you take a bowl, right? Something more tubular, things will go through quickly. Tenesmus are like drive heaves of the rectum. Like you're feeling you constantly need to go, right? And it's not always stool. It's like, again, air, gas, a mix of mucus and blood, a little bit of stool. And that can be very disruptive because you can't sit down and finish your work, you can't prepare dinner, you're sitting studying and you just have to constantly run to the bathroom. Again, because of the same things that's going on in the rectum. I showed you an image of Crohn's disease with a complication of a stricture and narrowing of the bowel. When things are narrowing down in the bowel, things are not going to go through that bowel easily. And this is when people can develop pain and bloating and constipation. And so it's important for people who are used to having more diarrhea, if you're having more now difficulty passing bowel movement, bloating, this could be related to a complication from Crohn's disease, okay? And overall, feeling crappy, right? Because what's important to realize that inflammation in the gut is not just limited to the gut. Think about when you have a sore throat or the flu or if anybody had COVID, right? It's all these inflammatory cytokines, those molecules that are inflaming the colon, they're circulating in your body. So it's like having the flu all the time, right? Just not feeling good. All right. So we talked about the GI symptoms and why they're here. How about what's going on in the butt, okay? And I feel very comfortable with this glamorous background of toilet seat talking about the butt. And so let's have a little bit of a lesson of anatomy. And this is why I put this slide up there. The anus is interesting because it's kind of the transition between the outside, the skin, and the inside, what we call the rectum and the colon. So the lining of the anus is made of the same lining as the skin, all right? So think about when you have a paper cut or when you cut your finger, with a knife while you're cooking, it hurts. And that's why anything happening in the anus hurt a lot, okay? It's also an area that's not very well vascularized, meaning we don't have a good blood flow there. So often things take time to heal, right? They don't heal well. So what could happen in a patient with inflammatory bowel disease, mainly with Crohn's disease? Anytime we see involvement of the anus, we have to think this is more Crohn's disease. A fissure is like a paper cut in the anus. We'll talk about anal tags. You might feel like lumps around the anus. The fistula are abnormal tract from the gut to the skin, and we'll talk about the abscess. All right. So this is, again, the anus is that skin going inside, and then it transitions to the colon skin. And again, if you have that paper cut, it hurts a lot. It bleeds. Every time you have a bowel movement, it's painful. So again, it's important to understand what's happening here and talk to your doctor about this. And this can occur if you're going a lot to the bathroom and you're irritating this area with diarrhea, or if you're straining and you have constipation. And what happens is when you have that pain, that muscle that's at the bottom of our anus that keeps us, that squeeze so we're not pooping all the time, squeeze it more, right? So if you have any pain, you go, right? So this was happening to that muscle, and when the muscle squeeze, it doesn't allow the blood flow to get into that area and heal the anus. So it becomes a vicious circle. You have pain, the muscle is squeezing, not allowing blood flow, not allowing healing, etc. So that's why the treatment that we have for fissure often involve something topical like a gel or a cream to decrease the pain, to relax the muscle, and allow the blood flow to come in and allow the fissure to heal. Unfortunately, sometimes these fissures can become a chronic problem and difficult to treat despite different therapies. This is what we call perianal skin tag. So you might feel around the anus like little bumps, like little rubbery bumps. And people confuse them with hemorrhoid because this is where hemorrhoids live also. And these are a perianal skin tag. And these are manifestation of Crohn's disease. It's like a swelling of the skin around the anus due to the inflammation. And then when they are less inflamed, they're less tender, but they can be irritating because the stool can catch there. It's hard to clean yourself when you have these tags, and so the stool can catch there and become very irritating. But what's very important is not to confuse those with hemorrhoid tags, because hemorrhoids, external hemorrhoid, when they dry, they also make these tags, and these tags can be removed by surgery. But with people with Crohn's disease, we don't want to mess in this area. Remember, I told you this is an area that's difficult to heal. So it's very important not to confuse these with hemorrhoid tags and get them removed by surgery, because that can lead to poor healing in that area. All right, fistula, that is really the most difficult complication to treat with Crohn's disease, and deeply impact people quality of life. And despite multiple therapy, we're probably able to heal at best around 50% of these fistula in our patient, unfortunately. But we have new therapies on the horizon, and we have hope that we can improve the life of our patient living with a fistula. So, do I have a pointer in this? I don't think there's a pointer. All right. So what I'm trying to show you here, so this colon that we saw, right, where you have that deep ulcer. Again, we're looking inside the colon at the inner lining of the colon, but that ulcer actually goes deep. It can go into the entire wall of the colon. So this is what the infographic in the middle is that the ulcer that we're seeing on colonoscopy actually can dig deep through the entire wall of the colon. And so this is where this abnormal tract formed. That's what we call a fistula. So it starts from where the anus or the rectum are, and it just digs through the wall and goes into, the skin fat and the skin muscle. And that's what a fistula is. It's an abnormal tract that's created because of the inflammation, and it just dig through the wall of the bowel and dig through the skin. So as you can imagine, now you have an abnormal communication between the anus, the rectum, and the skin. And so in that tract, you're going to have the stool, the bacteria, all this. And so it causes inflammation, right? It irritates this area. So at the exit of the skin of that fistula, you'll feel like a pimple, right? It's like a pimple that's hurting. And then sometimes, it opens up, it let go of the, the pus that's there, it calms down, and then you feel it again. So that is what a fistula. So the fistula is when you feel it on the outside around the anal area as a pimple, it's actually a tract that's coming from the gut and going through the fat and the skin and the muscle around the anus into the skin. Now, when this fistula, this is an endoscopic picture where I show you from the inside. You see this is the lumen, and up at 1 o'clock, you see the fistula opening. So this is from the inside, and it's digging through the wall, traveling through the skin, and opening up to the skin. And so as a patient, you see it on the skin, you feel it on the skin around the butt. As an endoscopist, sometimes we can see also the internal opening. So what also this fistula can happen is that it can get complicated with an abscess. So if you have all that pus and bacteria going into that abnormal tract, it can collect as a pocket of pus. And this is when you feel like pain in the buttock, pain when you're sitting, you can have fevers, chills. It's like any abscess, right? And so that is very important to recognize and to treat properly. This is not something that we cleanse in the ER and let it drain and go home. This really require the combination of a surgeon, of the gastroenterologist, getting imaging to identify what kind of abscess we're having, and really treat this in collaboration with a surgeon who would drain it properly, and then the gastroenterologist, to give the right antibiotic, and then the right therapy, typically biologic, to help prevent further abscess and close the fistula. Sometimes we put something called Ceton. Anybody who had a Ceton? So Ceton is a kind of a plastic thread. And in people who've had an abscess, we drain the abscess, but the fistula is still there, right? That's that abnormal tract. And when we start treatment to close the fistula can close in a very erratic way in different points. And what we don't want is this tract closing at different points and creating, again, a closed pocket of pus. So what we do, we often place a seton. It's a piece of plastic that's going to go through the fistula tract and keep that fistula open. But as we're using medical therapy, that allows the fistula to close kind of homogeneously from everywhere. And when we feel that the fistula is closing, we remove that seton, that piece of plastic, allow the fistula to completely heal. So that's why it's important to have these kind of complication handled by a colorectal surgeon with experience in IBD along with a gastroenterologist. All right. So we talked about why we can why IBD is really truly a pain in the butt. I think also what I hear a lot from my patient is that I'm just not feeling right? I understand I have diarrhea, I understand I have this is good, but why am I not feeling good? I'm still feeling fatigue, I can't focus, it's hard for me to get up in the morning, what's going on? And it's important to realize that, first of all, like I said, when you have active inflammation, it's not just in your gut, your whole body is going to feel it, right? So just that explains a lot of the fatigue and lack of focus and lack of energy, needing to sleep, having a restless sleep. And of course, if you're getting up at night because you have bowel movement, you're going to be tired. So it's important to give yourself a break when you have active inflammation and realize that it's really affecting your whole body. But also what's happening is, I told you that all the nutrients get absorbed by the small bowel, not by the colon. The colon only job is to absorb fluid and make solid stool. But when your colon is inflamed, it leaks out nutrient that you have in your body. So if you have inflammation of the small bowel, it makes sense. If your small bowel is inflamed, it's not capable of absorbing nutrients. But even when your colon is inflamed, it's leaking out nutrients. It's leaking out protein. It's leaking out calories. That's why you lose weight. You might feel weak. But specific location of inflammation can lead to poor absorption of certain vitamin, like vitamin B12. If you have inflammation anywhere in the GI tract, by losing blood, we lose iron, right? So we can have a low iron and develop anemia. And all these are a source of fatigue, hair loss, your nails are not looking good, the energy is not good, etc. So it's important as we're treating IBD to realize it's affecting more than the GI tract, way more. And then even when we heal the bowel, we need to address those nutrient deficit, right? So whether with a nutritionist to help you build back, a healthy, balanced diet that is comfortable with your gut, right? So when your gut has been inflamed, or sometimes when you have strictures from Crohn's disease, you might not be able to tolerate that big bowl of salad, but what your dietitian can counsel you is how to get your fibers in a way that's tolerated by you, okay? So, and it's important to correct all this nutrient deficiency. The other reason you don't feel great is because also IBD inflammation is not only limited to the gut. You can have inflammation in other part of the body as part of your IBD. The most common location are the joints. So if your joints are aching, your ankles are aching, your hips, your hands, your back, it's important to discuss this with your doctor. And it can be frustrating sometimes because often these joint pains seem to be moving around. So you think it's all in your head. Like, I woke up with a shoulder pain today, the next day it's my hip, this must be like me, and people don't take you seriously maybe. So it's important to realize that these symptoms kind of move around. What's interesting also is that you can have inflammation of the spine and the hip, and these pain can be very debilitating, and they mainly occur in the morning. You wake up, you feel pain and stiff when you rest, and as you move around, you feel better. So people might ignore that because we're all thinking about herniated disc or typical back pain that happen more when you're moving, when you're standing up. But the inflammatory joint pain is different. It's when you rest that you feel the pain more. So people are like, I'm trying to rest from my long day, and now I'm having pain. I have to get up, move around to feel better. And these are important to recognize and to treat because these joints can become stiff over time and can prevent you from bending over and doing some activities. So joints are one, skin inflammation is another one. And there's different skin manifestation related to IBD. eye inflammation, and then liver disease. So it's very important when you talk to your gastroenterologist, unfortunately, it's often our mistake that we don't ask about things outside the GI tract. I think for anybody who's had experience with the GI, we often go, how many bowel movement? Is there blood in stool? Do you have pain? And we stop there. And it's on us to ask you about other things, but also bring it up to your doctor, right? Bring up anything that's happening with you. Tell your doctor who's treating your IBD, because it could be related to IBD, and that can affect what medication we're going to use, what kind of follow-up you need, etc. What's interesting is some of these manifestation inflammation follow what's going on in your gut. So when your gut is inflamed, typically you get these big joint pains. Or when your gut is inflamed, there's certain skin disease that happen. And by controlling the inflammation of the gut, we control the rest. But some manifestations are independent of what's going on in the gut, meaning we can heal your gut and we still have that joint pain in your back. We might still have some skin diseases, some the liver diseases, and these need a separate treatment and separate attention, okay? All right, so these are some, I know we're all comfortable with the gut, but I want you also to be comfortable for other thing. For me, I never wanted to do derm. I always thought derm was just disgusting. And I'm like, and my dad is like, and poop is not? I'm like, no, the colon is beautiful. The terminal ileum even better. But we all have our thing, right? So these are some of the manifestation, right? So skin disorder, sores in the mouth, sores on the lips, eye inflammation, all these things, it's important to pay attention and realize they could be related to inflammatory bowel disease, and you need to seek attention for that. All right. So when you tell yourself, why am I not feeling right? Why am I not feeling good? I think it's important to just be kind to yourself and really remember that IBD affects your body in so many ways, but more than your body, right? We talked about GI symptoms, the pain, the diarrhea, the urgency, having to wake up at night. We talked about the extra GI symptoms, what we call extraintestinal manifestation, the joint pain, the skin disorder, how all these symptoms can affect your sleep, your energy, your fatigue, the deficiency in nutrients, having anal disease, having an ostomy maybe, having to go to all these GI visits. You go to the gastroenterologist and you go to the primary care and the surgeon and the infectious disease, and it's a whole calendar filled with doctor visit. I mean, I'm a physician, I live in the hospital. I carried my mammogram order for 2 years before I went to get my mammogram. I was ashamed of myself that it is so hard to get this done, right? And I see my patient, they have blood work and a colonoscopy and an MRI and all that stuff. So just doing all this is amazing stress on the body and on the mind. And it's affecting everything else, right? Your capacity to go to college, to work, to take care of your family, dating, having a healthy sexual life, having good sleep, having, being able to do a physical activity that you want, being able to go on a camping trip that you want, and you're focusing about how am I going to have access to a bathroom. So when you're not feeling good, it's absolutely understandable. And it's important not to feel that you should be able to feel better because you see other people like they're managing. It's important. I always try to think that we never know what's going on with other people's life, that Instagram is all fake, including mine, and we only show the best things, right? And we all have our challenges, right? So I think this is why, again, these kind of sessions and these kind of events are so important, to share these experiences and to feel comfortable talking about things, the real things, the uncomfortable things, and to give yourself grace. For anybody living with a chronic illness, it's so important to give yourself grace. You guys have amazing grit, right? Amazing resilience, but that resilience shouldn't be hanging over you like I always have to be resilient and happy and doing well. So give yourself grace and really kind of realizing that for most people living with a chronic illness or having a chronic problem or having IBD, this really affects your body in so many ways, your emotional health, your mental health. So, which brings me, talk to your doctor, and if your doctor doesn't listen to you, talk to another doctor about addressing your emotional health. There's now more and more data showing that depression and anxiety increase your risk of having a flare in IBD, and flaring and ending up in the hospital or being on steroid that drives you crazy are going to increase your risk of depression and anxiety. So it's very important, as we're talking about, GI wellness, it's also the head. Not because it's in your head, because this is a tough disease to handle. And we do need a healthy mind to help our body being healthier, okay? All right, so the next time you feel, you wonder, oh, I'm not feeling good, you have every very good reason. Give yourself some grace. You are showing up every day for yourself, for your family, for your friends, for your health, for your community, for advocacy, for everybody else. I believe people who are living with IBD are amazing beyond any measure. My patients ground me. They make me realize that if I'm upset because the coffee spilled on my pretty shirt is not a big deal. And they make me realize every day how much I have to be grateful for every piece of health that I have and for every time I'm sharing these moments with others. So I want to thank you for being here. I want to thank you for having me. I want to congratulate you on coming together as a community to improve education and awareness and advocacy. This is amazing. That in addition to struggling with a chronic illness, you are here to improve the lives of others, not just of yourself. So thank you for having me. The next time you don't feel good, remember you are amazing, and that's what I think. All right?